My name is Heun. I'm a consultant psychiatrist and editor of Global Psychiatry Archives, and today I would like to talk about the psychiatric consequence or sequelae of a stroke. A stroke is usually an affection of a brain vessel which has been blocked and which causes a deterioration and shrinking of the brain. There might be cognitive disorders which are resultant of the fact that brain cells die. This can cause progressive vascular dementia or non-progressive dementia if it's just the cause of a single stroke and not many small vessel affections. There might be an amnestic disorder if the memory cannot be stored, which might be the consequences of a ruptured anterior communication artery. However, what's more common, and it's a problem in liaison services, that we have a post-stroke depression. Depression might be very common, either by the frustration with the stroke, but also by the effect of brain areas and damage of brain areas. Depression can appear early or late during a stroke recovery and might be missed if the cognitive or communication impairment of functional outcome is poor, and then the focus is on these problems but less so on the depression. Risk factors for post-stroke depression are the severity of physical disability, such as the stroke severity, the amount of cognitive impairment, which are predictors of the depression. Women are affected slightly more often than men. The lesion location doesn't really influence the depression risk. The treatment is usually antidepressants, and SSRIs are widely used and usually well tolerated. So antidepressant medication can be used. And the other thing is that the personality can change and executive dysfunction can happen. So this might happen if there's damage to the frontal lobes, and this can cause the reduction psychologically, the range loss of intellectual flexibility, apathy, aggression, irritability, and loss of social sensitivity and loss of interest. So people might be very aggressive, inappropriate behavior, they might expose themselves, and these are things which are related to a personality change. Executive dysfunction usually means the inability to organize different sets of movements in a sequence, so people might not fully understand how to manage making a cup of tea, even though they easily can perform any individual tasks. So it's the executive function which is more or less localized in the frontal lobe, and that doesn't function anymore. A strange and not that briefing thing is the pseudobulbar affect, which means that there is a very emotional behavior. We call it emotional incontinence or pathological laughter or pathological crying. Can happen in up to 50%, and it also happens in other disorders. I've seen it very often in multiple sclerosis, and what you see then is that people can be very tearful or uncontrollably crying or laughing, which is completely inconsistent with the subjective emotional state. And this might also respond with SSRIs and with amitriptyline. Some patients with strokes can develop delusions, which might be, and this is not very frequent, the denial of ownership of a limb or half one's body. So people are not sure whether they have lost a body or whether they never owned a part of a body. So they can't relate to the side of the body at all. And this usually happens when people have right-sided lesions, and some people might also have schizophrenia type or schizophrenia-like psychotic disorders, which might again be associated with right-sided lesions. And there's also some affections in the pons and midbrain, which can lead to hallucinations, and they call it peduncular hallucinosis, and it's a very rare syndrome which has very complex visual hallucinations, so very detailed hallucinations. So these are the main problems you can have with a stroke, which usually are very sad, and the most common a liaison psychiatrist would see certainly is the depression after a stroke. Thanks for your interest, and hope you never have any relative or friend who suffers this type of problem. Thank you.